Many thanks for the opportunity to talk at the Combined Prostate Cancer Support Group of rural New South Wales. For those that don't know me, my name is James Symons. I'm a urologist based in Sydney. I provide a regional outreach service to the Riverina as well, with consultation in a face-to-face setting at our office at Riverina Urology. So I've been working in the prostate cancer space for well over a decade now, and part of my initial work was in the role of transperineal biopsy, which has then taken on and replaced transrectal biopsy as the standard of care. So we published our landmark paper in this in the British Journal of Urology back around 2013 or so, and then published the essentially the textbook on it in Symons thereafter. It's been quite a privilege to watch this rapidly distribute throughout the world, really, and replace the rather dirty and old-fashioned transrectal biopsy. Now, unfortunately, I can't be there in person today, so hopefully it's nice weather for you in Dubbo. If you feel like a coffee, I'd suggest that you go to Press, which is a great place, which my wife and I like to go to when we're in town. Although I don't go to Dubbo anywhere near as often as I'd like, my wife continues to maintain a service there where she visits in her own medical capacity regularly. We've also got strong links through to a lot of the medical families there. Now, moving through, so today I'm going to be talking about prostate cancer, obviously, and I'll give a general overview in this presentation today. I'm sure a lot of you will be aware of some of the content. There'll be a refresher, but there may be some new features through it. If you want to get in touch with me, probably the best way is through my office in Sydney with the sydneyuro.com.au website, or conversely via email at office@sydneyuro.com.au. Our main room's number is 1300 289 888. So today we'll be going through the current testing and assessment, including the PSA test and controversies therein, a general overview of treatment options for prostate cancer, lifestyle factors that come into play, and I've got a summary. At the end of it, I'm going to be adding in some newer slides discussing the role of theranostic services, particularly lutetium PSMA. For people who are interested, I've got a much extended 2-hour version, which the QR code to get through to it is here if you'd like to take a photo and scan that with your phones, or conversely, I'll have it up at the end of the talk as well. A few basic concepts as we begin. I'll be talking about the term clinically significant. So a clinically significant entity is something which, if we don't treat it, is likely to cause harm to an individual, especially if it's not treated in a timely fashion. A clinically insignificant thing is something which, whilst might be present, is something which is actually unlikely to cause harm to that particular individual over the course of their lifetime. The PSA is something that you'll hear a lot about. You've probably already heard it. The PSA is the prostate-specific antigen, and it's a protein found in the prostate. So prostate cancer, like many other malignancies, follows a generally traditional pathway, and I try and follow the evidence. When I'm seeing patients, essentially they'll come through, and there's obviously some degree of clinical suspicion for them to come and see me. And the aim is to establish what the grade of the tumour is, which is about how aggressive it might be. Then once we've got the grade, we then work to get a stage. And the stage is how far this tumour might have spread. There are various scans that we might do, which we'll talk about in a moment. And then, and only then, once we've actually got an understanding upon what it is that we've got and how far it's spread, do we then go down the path of actually formulating a treatment plan. So there's this stepwise sequence of events that I walk through with all the patients that come and see me. Look, I understand that people, when they come through, there's obviously a lot of fear and anxiety about what it is that might be going on to push their PSA tests up. There might be a family history of it. They might have friends or relatives who've had the disease. But before we can jump to treatment, and really people just want to be the other side of treatment and in the recovery phase, or not have it at all, there's a series of steps that we need to walk through, and you can't really jump from one to the end without having gone through the steps along the way. The current testing strategies that we'll go through, really we're looking at the PSA test. Unfortunately, there's no formal screening program for prostate cancer, unlike there is, say, breast cancer or bowel cancer. Really what we're looking at is early detection, and this is adapted to an individual's risk. The aim really is to, basically find these clinically significant tumours before they're likely to have potential to cause any harm to an individual. So in order to do that, you really need to go capturing a lot of people and monitor them for a prolonged period of time and try and separate out those tumours which are going to be the more aggressive ones and not, over treat especially those tumours which are unlikely to cause harm to an individual. The clinical examination, the finger test, which is sort of much spoken about in sort of hushed whispers, is still very much part of the workup for prostate cancer. It doesn't need to be painful and certainly isn't for most individuals. And it really shouldn't be a reason for people, particularly men, to fear coming in to see their urologist. The finger test is still a very important part of the examination, as around 15% of tumours won't necessarily secrete large amounts of PSA. And so the examination is going to be very important for that. It also helps us to work out how far some of these tumours might have progressed. Are they still in the prostate, or are they pushing into some of the surrounding areas? The PSA test, however, is the mainstay of early detection and then managing the patients once they've got a diagnosis. Essentially, the PSA is just a protein. Like any other protein in the body, it's got a role. And in this case, it's a liquefactive enzyme. What that means is it helps to break up mucus, and so it breaks up mucus in particular at the female cervix. So when a man's semen comes through, it hits the cervix, dissolves the mucus that's there to allow sperm to swim through, reach the egg and make a baby. It's got nothing to do with cancer at all, and is purely part of the normal reproductive cycle. So it's found in all prostate glands, not just the cancerous ones. But, and this is a big but, it's produced and it's excreted at different levels in those who have prostate cancer. So for those patients who have an abnormality in the gland, we start to see these PSA levels drifting upwards, and that becomes a bit of a red flag. It doesn't necessarily mean that they have prostate cancer, but certainly would suggest that they need to have some additional degree of interest put into that individual to make sure that we're not missing something. It's in the media very commonly, only very recently has it been in the Australian. Unfortunately, there's been some degree of discord, if you will do, between the College of General Practitioners and their guidelines and other key players within the country and internationally. Unfortunately, we sort of are at a situation now where the College of General Practitioners guidelines are relatively out of date and really don't follow what is considered to be best practice. Now, I understand that PSA testing is a controversial point, and part of the reason for the more conservative approach the general practitioners guidelines have taken is because they're fearful of overdiagnosis and overtreatment of clinically insignificant prostate cancers. These are things that men are more likely to die with rather than from. And that's certainly something that is a potential, and it's something that has happened, probably more in the past than it is at the moment, largely due to the advent of increased early detection strategies, which we'll come through in a moment. The evidence behind PSA screening, more as opposed to just advanced sort of testing strategies which we've got at the moment, based on population risk, come from large European studies. And what we're looking through, and there's some well-published things that you're very welcome to read through, which show that PSA screening definitely saves lives, but you've got to do it in the longer term. So for people who have very limited lifespan, the value in PSA testing in populations really isn't there. But for people who have otherwise good and robust health, then PSA testing is actually going to be of great significance for that person. If you're looking at a group of individuals, it shows that there's a significant survival advantage for patients if you go screening those people with regular PSA tests and follow them up to around 14 years. And beyond that time, there's significant improvements in survival, and then you get early detection. Early detection allows earlier treatment and then prevents an avoidable death in those individuals. And the risk reduction when you're doing that is equivalent to breast screening. So breast screening is already well established in this country, and there's no reason why, with an appropriate model, you can't have the same thing from prostate cancer, at least from my perspective. This has been shown in the ERSPC large multi-year follow-up data as well, in the most recent publication from 2019, which shows that if you're going out to 16 years, you need to screen 570 people and then diagnose out of that 18 in order to save one life. So yes, there's very large numbers of people that might need to have blood tests done, but again, a blood test is a blood test, and plenty of people are getting blood tests for multiple other reasons every year. So it doesn't really add much cost to the system, or certainly not much harm to that individual patient who's already going to get a blood test looking for diabetes or check his kidney function, to add on a PSA test into that mix as well. And if it's abnormal, you can flag it and then investigate it. There are a few caveats attached to the PSA test. I've taken this nice infographic from the Douglas Hanly Moyer website. And what we see essentially is the prostate volume increases with age. That might be one of the reasons the PSA goes up. The PSA will increase with age, just part and parcel of a few other things that are happening. But the median PSA, half the PSAs detected, will be below 1.6. In general terms, they're going to be below 2. We don't need to be too fancy about things. So essentially, if a man's PSA in the mid-70s is over 2, you really need to have a discussion about why that might be and investigate appropriately. There's a strong role for serial PSA testing. And really, what we mean by serial testing is that you don't do a test today and act upon the one test alone, unless it's sky high. Really, what you want to see is what the change is over time. A one-off result doesn't necessarily mean that somebody has to panic, but if it's high, we recheck it. If it's low, we get a data point, and we keep on getting extra data points over time. So, for my mind and my practice, it's sort of like reading the tea leaves. When I see patients and I follow them over a period of time, what I'm really doing is getting a feel for that individual's individual risk, and then based upon what that PSA changes over time, we can make a strategy about how often it is we might need to see them, and or about whether we might need to go doing an MRI or even a prostate biopsy. So the rate of rise for me is almost just as important as what the total amount is, and with 3 potential patients, the person in red down the bottom has a much more rapidly rising PSA, even though they're all roughly getting up to the same level at the end of time. And so if we have the PSA rise like that, that becomes a significant concern and prompts investigation. How do we investigate? Well, the mainstay of investigation is going to be through the prostate biopsy. But before that, we might often do an MRI. In fact, that's actually the standard of care in Australia more recently. But a diagnosis always comes down to a tissue sample. So this tissue sample is done through a small day surgery procedure where we capture some of the prostate. And it's a very safe and low risk procedure. I'm actually in the quite fortunate position to have, relatively early in my career, having published what at the time was the world's biggest series on transperineal prostate biopsy, and then gone on to write the chapter in the Urological Bible, which is Symons surgery, about the subject matter. Because what we're actually able to show when I had this series of 400 people from way back when, is that transperineal prostate biopsy had a significantly lower risk of infection than the old-fashioned transrectal biopsy, with needles that were going through a dirty route to get into the prostate. And so in days of yore, people would have a significant risk of infection attached to that, whereas with a transperineal biopsy, we come up through the skin only, and the risk of infection is now down to well below 1 in 1,000, which is deemed to be far more acceptable than what almost felt like Russian roulette, with about 1 in 20, 5% of patients coming back in with significant sepsis. Generally now, before we go down the path of prostate biopsies, in fact, people who have unexplained PSAs or abnormal examinations will go doing an MRI scan. So MRIs and potentially PET scans have become the new standard of care for the prostate cancer workup. MRIs are used for a whole host of other causes in prostate cancer. What we're really trying to work out is what's the probability that somebody will have a malignancy in their gland. You might see some scores attached to a report if you've had a PET scan. And this scoring system is called the PIRADS score, and it's really purely a probability-based score, from 1, which is considered to be a very low risk of malignancy, to 5, which is very high risk, and 3, which is indeterminate or equivocal risk, if you will, that a tumour may be present. In general terms, what we can interpret that as is, a treatment plan that comes from it. A PIRADS score of 1 and 2, you could watch it, at least for a period of time. PIRADS 3, you probably should consider doing a biopsy because it's considered to be a 50-50 risk of malignancy being present. And PIRADS scores of 4 and 5, a much higher rate of malignancy being there, in which case we'll go down the path of putting some needles in to work out what's what. The PSMA PET scan has also come around over recent times, which is the prostate-specific membrane antigen that we're checking for. So this is a target receptor on prostate cancer cells, means it's a protein that sits there. And we can bind it with a PET isotope, a nuclear isotope that has very low but safe doses of radioactivity, which will light up. And these PET scans are largely targeted to the prostate and done properly, they're about 25% more accurate than the traditional CT and bone scan, which is what was previously used. We can use the PET scans to add molecular information to an MRI scan. We can use them to find suspicious lesions that might be targeted in a biopsy. But very recently, the SAN had the MP4 trial, which is in publication at the moment. And PSMA PET scans can be used to see if the tumour is spread beyond the prostate, what we call staging scans. And this latter point is very useful, in fact so useful that it's finally been recognised. We've been using it for quite some time now, unfortunately at patients' expense, but as of the 1st of July, there's an MBS item number that's come through to bring the cost down and thus access to a large number of patients who previously couldn't afford it. The MP4 trial was funded so that patients were not disadvantaged. And in the MP4 trial, we were looking at using PSMA PET scans pre-biopsy so that people have an MRI scan and a PET scan. And that's also been quite useful to find some of the small tumours that were hiding where the MRIs couldn't see them. MRIs are not foolproof and they'll miss about 15% of tumours. So adding in this molecular imaging helps significantly to increase the accuracy of these patients. In fact, what we can then do, particularly at the SAM, we've got an excellent nuclear medicine department with a combination of radiology and nuclear medicine all working in unison, is we have the ability to fuse the PET scan and the MRI, and we can see some lovely images coming through. So in this particular patient, we have a tumour really just lighting up within the prostate. Unfortunately for that individual, we also have some spots in the bone, which we can see there as well as the glowing red objects. The large red one in the middle is the bladder, which is where some of that contrast is coming through. There's also, for some of the keen eyes, a large lymph node sitting in front where some of the prostate cancers unfortunately spread to as well. So if we have a look at that standard MRI scan on the top right, we have a dark patch at the back of the prostate. That dark patch is the tumour, and that has good concordance or agreement, meaning there's an overlap between the MRI scan and the PSMA PET scan, which means that the hotspots that are coming from the prostate, or hotspots that are elsewhere, will be the hotspots that are coming from the prostate. So we know then that that individual unfortunately has tumour that's gone from the prostate to those other sites. Here are a couple case studies that sort of show what more advanced prostate cancer looks like. And unfortunately, if we have a look at these individuals, their PSAs were quite high. If you go back to 2013, we have PSAs that were relatively high at 6 and 7 over the years. And this is what happens. Unfortunately, I'm seeing quite a lot of it this year because of COVID with late diagnoses of people coming with PSAs in the 50s or 100s, where unfortunately this individual came in with a PSA of 1,250 and bone pain. And lots of his bone lighting up. It's not surprising when he's got that many bone hotspots that he might have prostate tumour around the place. And put some needles into that individual, and we have high grade, Gleason 9 prostate cancer. And unfortunately, Gleason 9 prostate cancer left untreated as we go before, becomes this rapidly spreading thing, which goes from a PSA of 7. And then, a couple of years later, it goes up to 1,250 into something which is incurable. Another individual over here has had his PSA slowly rising from 3.7 to 4.5 to 5.4 over several years. And then we leave it 18 months, and all of a sudden it shot up to 50. Patient's seen me. I've confirmed that with a repeat PSA check to validate it. And very interestingly, for this particular individual, that PSA rise from 5.4 to essentially 50 took 21 months, and then from 50 to 64 only took 20 days. So here we have the PET scan showing relatively small tumour in the prostate, but invading into the seminal vesicles, these glands at the back. And then if you look on the left-hand side, there's lots of black spots running up in the abdomen, which are all lymph nodes where it's spread to. So when we have a look at a patient, and then we've got a patient with prostate cancer, whether it's confined to the prostate or spread, we really need to tailor our treatments. Not any one individual will get the same treatment as the person next to them. So just because your neighbours had prostate cancer doesn't mean that's necessarily going to be the treatment that's appropriate for you. The questions I want to ask myself for anybody, is the cancer clinically significant? And if it's not, well, do we even need to treat that individual? If it's clinically significant, do we need to treat now, or can we wait? Can we treat in the future? And if we can safely watch the patient, perhaps we can watch them indefinitely. But there's a path for that, which is called watchful waiting, which will be for those patients who are generally considered to be old and frail, or they're just of a stage in life where they might be frail, but they're more likely to have one of these tumours that you die with rather than from. When those needle biopsies come back, we get a grade score, which runs from 1 to 5. Historically, this was called the Gleason score, and the grade group score has been around for a number of years now and tends to replace that more historical Gleason score. In general, what we're looking at is what they look like under a microscope, and that gives some indication of how aggressive we need to be in our treatment. The more aggressive they are, the higher the grade score, the more we might need to consider throwing the kitchen sink at that individual. If patients have a very low grade group score, grade group 1, maybe select groups of grade group 2, then active surveillance is going to be most appropriate. So active surveillance is a term you might be aware of, and actually is the most commonly used means of treating prostate cancer in Australia at the moment. So active surveillance is suitable for about 70% of men with a newly diagnosed prostate cancer and has excellent cancer-specific outcomes. The aim of it is to spare the risks of overtreatment, and essentially for those patients who have disease progression, they're the ones who we might be able to go do treatment for. There's been a great paper published very recently, so this from 2020 in Journal Urology, and at the top line it's showing patients with grade group 1 varying forms and grade group 2 disease and their survival, and you really see that it doesn't move at all. So these people followed for 7 years have excellent cancer-specific survival. Patients tend to have a bit of a fear that they've got a new cancer diagnosis, but grade group 1 disease is not the same as that grade group 5 disease and is not going to behave the same way. So for most people, we can very safely watch that. That said, active surveillance doesn't mean no treatment, which also some people might fear. Active surveillance means we monitor people actively, and if we see that things move, then we can go down the path of treatment. We do know that some active surveillance patients may go on to needing something done. And the intervention rates, which we can see there, show that depending upon what the PSA levels are like and depending upon what the grade group is, different patients will need intervention at different rates. In general terms, somewhere between 40 to 70% of patients will make it out to the 7 years without needing any treatment. So something in the order of about 60% of patients will go through a relatively long active surveillance pathway without having anything done. Watchful waiting is not really the same as active surveillance. Watchful waiting is where we don't actively watch them. We don't go down the path as we do in the surveillance pathways of doing regular MRIs, PSA checks, repeat biopsies, potentially. No, watchful waiting, we have somebody who we try and spare a lot of the potential harm and angst of prostate cancer management for. We're just going to check their PSAs periodically and or wait for them to show symptoms, things like bone pain or difficulty passing urine because the tumour's grown up and causing true blockage and just, like this tight rock they have to pass urine through. We're taking chances, essentially, for this individual that they're probably going to die many years before their prostate cancer will catch up to them. And watchful waiting is another very appropriate way to manage a lot of the older chaps who might get a diagnosis of disease. Surgery, which is what I do a lot of for patients who go down the path of curative intent, is a great way of treating the younger man who wants to spare some of the toxicities that might be attached to hormonal manipulation and really is looking to get good functional outcome. Um, what we do with surgery is to go removing the prostate, and we remove the prostate with three aims. We're aiming for the trifecta, particularly if it's a young person who's sexually active. We're looking for cure, which is removal of the prostate and the cancer within it. We're looking for continence, and we're looking for potency. It's a general term, general concept, I should say. The aim is to try and gently tease off the prostate from the bladder neck. We'll separate it from the base of the penis. And on select patients, we'll be able to do a nerve sparing procedure as well. We can gently spare the nerves and tease them off of the prostate and the surrounding structures. And once we've done that dissection, we can then remove the prostate and join it back up again. It's a very delicate operation, which we do regularly up at the SAM. We've got teams of very well-trained individuals, myself amongst them. It's something that we've been doing for years and have helped hundreds, thousands of men with prostatectomy. Generally is done through a robotic approach. The morbidity, how patients feel afterwards, is significantly diminished if you go through a keyhole approach, where they're normally home within 2 or 3 days. Catheter time is far reduced for these individuals. We get great functional results. Blood loss is very low. Prostatectomy is by no means the only way, and I'd encourage a lot of patients to see a radiation oncologist as well. So I think it's very important that people get a balanced approach, because for most people, radiotherapy will be a very reasonable, if not just as good an option for them, and it offers comparable long-term cancer control to surgery. Radiotherapy can be given in multiple different flavors. Those flavors that we're looking at include external beam radiotherapy, where the X-rays come in from all around and generally paint the prostate. That external beam can be in various flavors as well. And there can be high dose rate brachytherapy. Tends not to be done quite as much anymore, but that is where we have high dose targeted radiotherapy put in through little tubes up and into the prostate. Or there's low dose rate brachytherapy. Brachytherapy is where these brachytherapy seeds, where we put radioactive little pellets that sit inside the prostate forevermore, and over the next couple of years they will distribute their radiotherapy to a little field around where they've been placed and neutralize the prostate. Those brachytherapy forms have generally become less popular as time's moved on, largely because the external beam radiotherapy is so good, and also because the radical prostatectomy, particularly the keyhole approaches and or active surveillance, have taken the place of the low dose brachytherapy. Hormonal control is the backbone of treating the metastatic prostate cancer. And in general, the hormonal control is something that people try and avoid at all costs, but is a necessary evil if we look at it as that way. Hormonal control, really what we're talking about is androgen deprivation therapy, which is some way of depriving men of the testosterone, which is the fuel behind their prostate cancer. Unfortunately, it can be associated with a male menopause, a relatively rapid one, hot flushes, night sweats, low energy levels. As a clinician, there are things that I need to do to try and support patients. Their GPs can do as well. It can cause relatively rapid bone demineralization, which is where you lose some of the density of the bone, so you get premature osteoporosis. Metabolic side effects with changes in weight, energy levels. You can be having changes in cardiac performance and fatigue. Can be a bit of an issue. And because you take away a man's testosterone, some of their vim and vigor can go, a little bit of their mental acuity can be dampened, and it can have significant effects upon a man's libido and prowess. In order to try and affect a better quality of life for individuals, we can go down the path of using some intermittent androgen deprivation therapy. We only use it temporarily, or we can look for other means in some people. Avoidance altogether is going to be the aim. And the best way to go doing that is to get early detection of patients and early treatment. In general, a timely diagnosis and then early treatment can avoid or postpone the time for androgen deprivation for individuals. And so that's one of the prime reasons for high-risk individuals, why we want to capture them early, is because a diagnosis earlier in life can pay dividends later life for that person. The medical oncologists, such as Professor Marks, no longer considered to be late-stage doctors. I work far more closely with them now than I ever did during my previous years. And one of the great things about the SAN, particularly the Integrated Cancer Centre, is that it's a truly collaborative sort of team care environment. What we're really seeing now with medical oncologists is this blending of the clinician sequence. So rather than the medical oncologists come in, we consider these chemotherapy doctors at really late stage, is we're bringing them in much earlier on the piece. And so these clinical trial drugs are extending into the surgery space and into the radiotherapy space. So 10 years ago, when I was one of the fellows at the SAM, the treatment options were relatively limited in the medical oncology space. Move forward to 2019, and we've shifted massively. And we have all these different treatment paradigms, all these extra trials have come through, a lot of extra clinical trials that we have data from, a lot of clinical trials that we're currently enrolled in. So the treatment options for patients with more advanced prostate cancer has extended massively, and we're drawing upon some of that experience to bring it into the early space with active involvement from the medical oncologists. Often from the time of diagnosis, when I'm discussing patients at a multidisciplinary team meeting for a collaborative care environment, we'll link them in, where appropriate, for involvement in clinical trials that we can do pre-surgery or pre-radiotherapy. And it really is a promising sort of environment to be working in. Now, a lot of people, particularly if they've got a new diagnosis, want to know what they can do. And that's actually the case whether it's a prostate cancer or it's a bladder cancer or really anything else going on. People like to think that there's something that they can do to affect a better outcome for them. Unfortunately, for a lot of people where they've already got the cancer, it is already there, but there are definite things that can be done to improve somebody's risks moving forward. And the elephant in the room really is actually weight. Australia has big issues with obesity, not as much as maybe some other nations overseas, but within the population, there's a high number of people who are carrying too much weight. And unfortunately, there's a significant overlap between patients who have prostate cancer or other cancers and malignancy. Malignancy is going to be more common in patients who carry excess weight. And in addition, for patients who have prostate cancer, for a person who's actually clinically obese, they have a 20 to 30% higher risk of death from their prostate cancer, independent of whatever their prostate cancer is like. So, unfortunately, patients might think that I harp on a little bit when I try and encourage them to lose weight if they're sitting at 115, 120 kilos, and they have done for a number of years. But the best thing that person can do is try and bring their weight down. We know that basically it's going to give them better bowel control, better bladder control, better for their arthritis, better for their heart, better for their cancer as well. And patients really should be proactive. People who are diagnosed, get a new diagnosis, active surveillance, or trying to prevent the disease, then working on the weight is going to be something that's going to be of significant benefit. In amongst lifestyle factors, there's no time for smoking. It really needs to be something that people try and work on. I'd encourage patients to go down the path of doing smoking cessation pathways where possible. I'm certainly not judgmental. People will have their vices, and why people smoke is entirely up to them. But it significantly increases somebody's risk of bladder cancer, significantly increases the risk of kidney cancer, which I'll treat, but also increases massively the risk of prostate cancer, and it's a very avoidable harm for patients. Alcohol, all things in moderation, really. Alcohol is something that, particularly in higher amounts, will increase cause mortality and contribute towards excess calories. People like to think that they can try and make major dietary modification. Really, cutting alcohol, cutting sugar down as well will be beneficial for patients. It will be better for their weight loss. There may be some evidence behind insulin resistance contributing toward tumour progression, but we don't really need to get patients onto some of the diabetic medications. They're really just better off to try and work on the harder things to fix, which are not taking a pill. It's going to be working on their weight. People like the idea of dietary supplements as well. Unfortunately, I'm not going to stop people. I'm happy for people to take what they want in this space, but there's little evidence behind it, and people need to be aware of that. In some ways, a lot to go through. So I've been trying to talk about, 20 years worth and try and get it into 20 minutes. But essentially, talking from before, COVID has led to a decreased diagnosis of a number of prostate cancers, prostate cancer among them. Unfortunately, a delayed diagnosis risks stage migration, which is where tumours go from being something that's confined to the prostate to then spreading beyond it. And what we see is, and it really breaks my heart when I see these people come through with PSAs of 100, when they were seen well before and just wasn't acted upon. is that they've gone from something that was curable, and they've moved through the difficult to pass throw the kitchen sink at them stage to an incurable state. We can manage it. There's certainly pathways, the medical oncologists or cytoreductive prostatectomy or radiotherapy, but ultimately, for people who have metastatic disease, presenting with high volume disease, it's going to be something that will be incurable, and is a true shame, particularly when you're somebody who's presenting in their 50s. That said, most men with prostate cancer will not die of the disease. And so, an early detection is going to be useful, but doesn't mean that just because you've got a diagnosis, it's something to be fearful of. Some men may, and because some men may, we really need to try and separate out the wheat from the chaff. We need to find that needle in the haystack who is going to be the aggressive cancer. Use biomarkers, use PET scans, try and work out who are the really high-grade cancers that need to be diagnosed and treated, and then treat those actively who need it, and then not treat, but put onto active surveillance pathways those who don't need treatment. My thought is that knowledge is power. There's been some discussion, particularly at that GP level, and in that Australian article they made mention to, that a diagnosis causes unnecessary anxiety. I think that's a bit of a furphy, and basically ignores the intelligence of a lot of individuals. I think people have a right to know what's going on within inside them, and an early diagnosis shouldn't necessarily be something that should be avoided because of a misplaced fear of causing anxiety. I think it's important for people to know what they've actually got going on within them and manage it accordingly, not necessarily aggressively, but manage it in a planned sequence so that when things do start to change, things if they are aggressive, people can make informed decisions. But withholding that information from people doesn't allow them to make an informed decision at all. In summary, for what sort of strategies do we have for early detection? It's going to be around a PSA test, which can be done with a general practitioner, or if there's a strong family history, with a urologist. In general, if there's a family history, you start early and you do it regularly. You should remember for yourselves that the median PSA should always be below 2. And if things are higher than the median, then they need to be investigated appropriately. The finger test should also be done, in general, every 2 years or so. Now, a lot of general practitioners are not necessarily very keen or experienced in doing it. The type of medicine they practice has changed. In that case, if people have high PSAs, then it's something that urologists will be very capable of going to do. The Cancer Council has very good guidelines, very long guidelines that you can read through. I'll put an abbreviated URL there. So the short URL, you go and type in AGMX6, and that will bring you through to the long gobbledygook sort of URL for the Cancer Council's clinical guidelines. Thank you very much for your time tonight, and I hope you found some of this interesting. If you've got any questions, just let us know. We'll be happy to have a chat. Thank you. So theranostic services are the idea of where therapy can also actually be delivered through what was previously a diagnostic service. In particular, when we're talking about theranostics and the role of prostate cancer, we're talking about lutetium therapy. And therein we're using lutetium, which is a radioactive particle, which is bound to the PSMA molecule. The PSMA molecule is upregulated in prostate cancer cells about 1,000-fold in the high-grade tumours, and thus when you have radioactive lutetium bound to the PSMA and then it's injected, that then distributes throughout the body and essentially binds onto these prostate cancer cells, delivering high-dose and highly targeted radiotherapy. At Sydney Adventist Hospital, we're currently running the SLAP trial, SLAP, which to the best of my knowledge is the only theranostics trial currently recruiting in Australia. So the SLAP trial, which is currently open to new patients, is looking at the role of salvage lutetium after prostatectomy. So in this setting, we have patients who have had a prostatectomy for their high-risk disease, and then unfortunately have disease recurrence. And so the aim here is to deliver lutetium in a relatively early setting. At the moment, otherwise, lutetium is otherwise controlled through the special access scheme and is only available for patients who have tried and failed systemic androgen deprivation therapy and chemotherapy. So the role of the trial is looking to bring theranostics into much earlier into the metastatic or local control failure setting. Now, as mentioned earlier in the talk, I've got an extended 2-hour version for those keen members of the audience. The QR code is here, which should be scannable with your phone to take you directly through to a auto-playing YouTube video, or conversely, you can type in the text there. In this talk, I go through a more detailed discussion about the prostate gland and what it's used for, actually, why the body actually has a prostate gland. Also an overview of lower urinary tract symptoms, given that a lot of men that present through to a urologist will have some underlying voiding symptoms. And additionally, a lot of men with prostate cancer, particularly if they're on an active surveillance program, may go on to develop issues with their voiding, and that needs to have a discussion and potentially treatment. I also go into greater depth regarding the role of PSA and PSA screening, and also prostate cancer and the various investigations that come into play and the treatment options available. Many thanks for your time, and I hope you get something out of this weekend. All the very best. And lastly, I should say, if you have any questions, feel free to be in touch. Just shoot an email through. Thank you.